Klote, and this is my presentation for my DNP scholarly project for Maryville University entitled Ventilator-Associated Pneumonia Prevention Checklist, a Quality Improvement Retrospective Chart Review. Committee. The assigned DNP chair from Maryville University was Dr. Rochelle Davis, and the community member is Jamie Collins, who is an APRN who works within the oncology ICU where this project was implemented. She is well versed in this specific patient population as well as critical care medicine. Project overview. The purpose of this scholarly project was to implement a VAP prevention checklist in the oncology intensive care unit with the aims to increase the nursing staff's compliance with VAP prevention practices and decrease the overall VAP rate of the intensive care unit. Background. VAP is a form of nosocomial infection where a patient receives a new or progressive infiltrant of the lung on imaging within 48 hours of mechanical ventilation. VAP is associated with longer hospitalizations, increased healthcare costs, and worse patient outcomes. The oncology patient population faces a higher risk for VAP than the general patient population, like all other forms of nosocomial infections. Methods. A retrospective chart review of the electronic medical record of all the patients in the oncology ICU who required the use of a ventilator was performed for this scholarly project. Quantitative data was collected for all of the 6 different ventilator-associated pneumonia prevention practices that made up the VAP prevention checklist, as well as the overall VAP rate. Results. Outcomes of the retrospective EMR review showed a 23% increase in the nurses' compliance with VAP prevention practices. However, there was not enough sufficient data to suggest statistical decrease in the VAP rate from the pre to post-intervention group. Conclusions. While the expected outcome of this project was not met, one of the 2 aims of the project was met. There was enough data to show a statistical improvement in the overall compliance rate of the different VAP practices. This therefore created an implication to nursing practice by improving the quality of care given within the oncology ICU. It additionally created implications for future research where it can be used again by the oncology ICU or another unit struggling with compliance issues of VAP practices. Chapter 1, Phenomena of Interest. Mechanical ventilation is a very necessary medical intervention that is incredibly beneficial when a patient faces an extreme form of respiratory failure. Mechanical ventilation will support a patient's respiratory system through the use of a ventilator that will simulate breathing for the patient and deliver a higher percent of oxygen to their lungs. One of the biggest risks when using mechanical ventilation is ventilator-associated pneumonia, or VAP. VAPs are one of the most common nosocomial infections seen within the critical care setting. The goal of this scholarly project was to address the issue of VAPs, specifically the VAP rate within the oncology ICU at Barnes-Jewish Hospital. This specific patient population faces an increased challenge due to the fact that a majority of this patient population is immunocompromised. This means they face a higher risk for infection, including VAPs as well. Interest. This topic became of interest to me during my current work experience as a bedside nurse in the oncology ICU. I became aware of this issue when I had a discussion with the nurse manager of my unit who mentioned that the VAP rate had steadily been increasing for over the past year. When discussing ideas with her about how to address the issue of the increasing VAP rates, she mentioned that she believed that our ICU had the guidelines in place for VAP prevention measures, but the compliance with the nursing staff was the main part of the issue. Through this, we developed a plan to implement a checklist for the nurses that focuses on VAP prevention strategies. Purpose and aims. The purpose of my scholarly project was to implement a checklist that focuses on VAP prevention practices for the nursing staff of the oncology ICU at Barnes-Jewish Hospital in St. Louis, Missouri. The prevention practices include elevation of the patient's head of bed above 30 degrees, daily sedation interruptions and breathing trials, frequent subglottic secretion suctioning, frequent oral suctioning, the use of chlorhexidine daily for oral care, and brushing the patient's teeth. There were 2 main aims of this scholarly project. The first aim was to promote the use and increase the compliance of VAP prevention practices for the nursing staff. The second aim was to decrease the overall VAP rate of the oncology ICU. The overall goal of this scholarly project was to improve patient outcomes within the oncology ICU. Chapter 2, Literature Review. The specific population intervention comparison outcome, or PICO question for this project was, in adult oncology patients on ventilators, does the implementation of a ventilator-associated pneumonia prevention bundle checklist, when compared to not using the bundle checklist, increase the compliance of the nursing staff with VAP prevention practices or decrease the risk of ventilator-associated pneumonia? The overall aim of this project was to answer this question. The aim of this current chapter was to discuss the search history, the integrated review of literature, the literature critique, the concepts and definitions, and the theoretical framework of this project. Theme 1, ventilator-associated pneumonia. Ventilators are a necessary form of medical equipment that can sustain a person's life, especially if their lung mechanics are failing. Some cases where it could be appropriate to put a patient on a ventilator would be respiratory failure, where non-invasive forms of oxygenation have not been successful, extreme metabolic or respiratory acidosis, or in the case of poor mental status where the patient is not protecting their own airway. Ventilator-associated pneumonia is a common nosocomial infection that occurs when a patient develops a new or progressive infiltrate on any form of imaging of the chest that has occurred 48 hours after intubation and mechanical ventilation. It is also associated with fevers, change in leukocyte count, and changes in sputum. Ventilator-associated pneumonia can be categorized into two types. Early onset ventilator-associated pneumonia occurs within the first 4 days of intubation and mechanical ventilation. Early onset ventilator-associated pneumonia accounts for about half of the ventilator-associated pneumonia cases and is more likely to be caused by antibiotic-susceptible bacteria, meaning that they are typically better patient outcomes for this form of VAP. The second type of ventilator-associated pneumonia is considered late onset, which is a pneumonia that occurs after the initial 4 days of ventilation. Late onset VAPs are more likely to be caused by gram-negative bacteria and therefore harder to be treated. It is also associated with a higher morbidity and mortality rate. VAP statistics. Ventilator-associated pneumonia is the most common form of nosocomial infection seen within the ICU patient population, occurring in 10 to 20% of mechanically ventilated patients. The International Nosocomial Infection Control Consortium has found that the overall ventilator-associated pneumonia rate is 12.2 per 1,000 ventilator days. Within the United States, there are between 250,000 and 300,000 cases of ventilator-associated pneumonia annually. In addition to this, 86% of nosocomial infections are associated with mechanical ventilation and can be considered a VAP. On average, a VAP adds 7 to 9 days to the time spent within the hospital for the patient. Increased mortality rates have also been associated with cases of ventilator-associated pneumonia, with the average increase of 30%. Additionally, 36 to 60% of all healthcare-associated infection-related deaths can be attributed to ventilator-associated pneumonia. Unfortunately, these patients can also be affected financially as well, with the average increase in healthcare costs being around $40,000 per patient with ventilator-associated pneumonia. Theme 2, VAP prevention bundles. There are 6 key practices that are common in most all of the VAP prevention bundle sets used widely within critical care. The first aspect of the bundle is the elevation of the patient's head of bed to 30 or 40 degrees. The prime motivation for this is to prevent the aspiration of oropharyngeal or gastric contents. The aspiration of these contents are seen more when patients are laying in a supine state, which has also been associated with higher rates of VAP. The second aspect is daily sedation interruption and assessment of readiness for extubation. The rationale for this is due to the fact that the more prolonged mechanical ventilation, the more likely the patient is to be exposed to VAP. By the performance of frequent breathing trials, this increases the likelihood of a faster extubation. The third strategy for prevention of ventilator-associated pneumonia is the use of subglottic secretion drainage. This is where the medical practitioner threads a thin catheter through the endotracheal tube to go past the cup at the end to suction out the secretions from the lungs. This prevents secretions from pooling, resulting in a pneumonia. The fourth strategy of the ventilator-associated pneumonia prevention bundle is the frequent oral suctioning. This is performed by taking a small oral catheter and sweeping it through the patient's mouth. This removes secretions that can enter the lungs and then result in a ventilator-associated pneumonia. The fifth preventive strategy for ventilator-associated pneumonia is the use of daily oral assessment and care with the use of chlorhexidine, and the sixth prevention strategy is brushing the patient's teeth. Both prevent ventilator-associated pneumonia in the same way. They can be beneficial in the prevention of ventilator-associated pneumonia because it reduces the bacterial colonization of the oropharyngeal area. This lack of colonization promotes less bacterial spread down into the lungs of the patient, where it could colonize there and become a pneumonia. Theme 3, oncology patient population. This population differs from the general patient population because of the comorbidities associated with the care and treatment of their cancer, which put them at a higher risk for contracting infections such as ventilator-associated pneumonia. Their need for invasive mechanical ventilation can be caused by both infectious and non-infectious causes. Oncology patients have a higher risk for developing pneumonia, respiratory failure, sepsis, pulmonary embolisms, pulmonary edema, and transfusion-related acute lung injuries. All of these combined put the patient at a higher risk for needing ICU-level care and mechanical ventilation. In addition, oncology patients have a higher risk for nosocomial infections due to immunosuppression, the receiving of active chemotherapy treatments, frequent disturbed skin and mucosal barriers, frequent hospitalizations, frequent use of antibiotics, and the use of invasive lines or devices. Multiple studies have found a higher VAP rate within the oncology patient population. The oncology patient population has a ventilator-associated pneumonia rate of 24.5 for every 1,000 ventilator days. Literature critique. The strengths noted during this literature review were the multiple research designs used and the large sample sizes within the different studies. One of the weaknesses found within the literature review is the lack of generalizability for some of the studies performed. This restricts the different studies' ability to be randomized and contain a diverse population and makes the sampling more based in convenience. A main gap found within the literature review was the lack of literature that specifically looked at oncology patients in relation to ventilator-associated pneumonia. It could be assumed that the lack of literature on this topic is most likely due to the lack of environments that are specifically designed for oncology patients that have critical care capabilities. In addition to this, it was noted that there was a lack of literature that combines all three of the themes identified from the PICO question of this scholarly project. Due to the previously mentioned weaknesses of the literature, one limitation of this literature review was the possible lack of generalizability to the oncology patient population. Theoretical framework. The theoretical framework from which this scholarly project was guided off of was the framework for guiding the process of implementation by Howes and Quinn. This framework is described as a how-to list for those who are trying to implement change. It can be broken down into 2 phases, and each phase has 6 different steps. The goal of the first phase is to make an adequate orientation to the environment in which the change will occur. This helps to prepare and positively influence the change. The second phase of this framework focuses on establishing networks for the implementation effort. This helps to ensure that the change actually occurs by facilitating an environment that will support it. Chapter 3, Methods. Methodology. This was a scholarly project for the Doctor of Nursing Practice program at Maryville University. The scholarly project was a retrospective chart review that collected quantitative data. The sample included the electronic medical records of the adult oncology patients who required the use of a mechanical ventilator. Prior to the intervention of this scholarly project, there had been no consistent process to reinforce the ventilator-associated pneumonia prevention practices for the registered nurses of the oncology ICU. Design. Inclusion criteria. The participant must 1. Be 18 years of age. 2. As a nurse, have attended new employee registration and new nurse orientation at Barnes-Jewish Hospital. 3. As a nurse, be enrolled as a registered nurse within the oncology ICU at Barnes-Jewish Hospital. 4. The EMR of the patient has documentation of an oncological diagnosis during the time of the scholarly project. If not, the EMR was closed and no data was retrieved. 5. The EMR of the patient has documentation of mechanical ventilation during the time of the scholarly project. If not, the EMR was closed and no data was retrieved. Exclusion criteria. Participants may not be 80 years of age or older. 2. Be a staff member of the oncology ICU for less than 4 months. 3. Be a medical professional other than a registered nurse. 4. The EMR of the patient does not have an oncological diagnosis during the time of the scholarly project. If it does, the EMR was closed and no data was retrieved. 5, the EMR does not have documentation of mechanical ventilation during the time of the scholarly project. If it does, the EMR was closed and no data was retrieved. Step-by-step outline. Within the next 3 slides, the step-by-step outline of this project's protocol is listed. If you would like to read the step-by-step outline, please stop this presentation now. Chapter 4, Findings. Analysis of data. All data was analyzed with the assistance of Maryville University's statistician, Dr. Pauls. The analysis was completed using Statistical Package for Social Sciences, or SPSS, to process the data collected by the researcher. There were no missing data, additional or purposeful exclusions, or reverse events during the time that research was collected, which would skew the results of the data collection. Data presentation of nursing compliance with VAP prevention practices. The data collected from the EMR during the scholarly project was used to analyze the compliance of the nurses of the oncology ICU when it came to the 6 different VAP prevention practices that were incorporated into the VAP prevention checklist, which was the intervention of this scholarly project. The desired outcome of the scholarly project was the increase in nursing compliance when it came to the average of the 6 practices performed by the nurses. The data collected through the EMR was placed into SPSS to evaluate the statistical significance of the pre- and post-intervention period by using a z-test of 2 proportions. The next few slides show the different statistical findings of the VAP prevention practices between the pre- and post-intervention group. Data presentation of VAP rate. The data collection from the infectious disease department during the scholarly project was used both to analyze the overall VAP rate of the oncology ICU during both the pre- and post-intervention groups. The desired outcome of the scholarly project was to decrease the overall VAP rate of the oncology ICU through the intervention of the VAP prevention checklist performed by the nursing staff. The data collected from the infectious disease department was placed into SPSS to evaluate the statistical significance of the pre- and post-intervention period using a z-test of 2 proportions. The next few slides show the different statistical findings of the VAP rate between the pre- and post-intervention group. Results. Outcomes of the retrospective EMR review showed a 23% increase in the nurses' compliance with the VAP prevention practices. This compares the pre-intervention group, where there were 221 interventions out of a possible 492 completed, to the post-intervention group, where there were 295 interventions out of a possible 432 completed. This provided sufficient enough data to suggest an increase from the pre to post-intervention groups. However, there was not enough sufficient data to suggest a decrease in the VAP rate from the pre to post-intervention group. The data collected from the infectious disease department of the facility showed the pre-intervention group having 2 VAPs out of a possible 82 participants, whereas the post-intervention group had 2 VAPs out of a possible 72 participants. Therefore, the confidence interval does not suggest a true change from the pre to post-intervention. Chapter 5, Discussion. Limitations of the study. The main limitations of this study were that this scholarly project was performed in a single medical center, and the overall number of participants was lower than was initially hoped for. There was data collected on 154 participants, which was the number needed to have statistically relevant data. However, these results would be stronger if there were a higher number of participants, which was initially hoped for by the researcher. The main reason for the lack of participants was the overall time frame of the data collection. To combat this limitation, the researcher extended the time period for data collection from the initially planned time frame of 3 months to 4 months. However, this extended time frame of 4 months only led to the collection of the data needed to be statistically relevant. making the results of the scholarly project valid. The limitations of the scholarly project being performed in a single medical center was something that was always planned from the beginning of this project. With the focus of this project being quality improvement for the specific unit of the oncology ICU, this meant the focus of this project was on a specific medical center. Interpretation. A possible reason for the differences between the observed and expected outcomes of this scholarly project could be due to the differences in the length of time the participants spent on the ventilator total. For example, the 2 participants in the pre-implementation group who got a VAP were on a ventilator for 6 days and 16 days, whereas the 2 participants who in the post-implementation group who got a VAP were on a ventilator for 15 days and 39 days. Therefore, the factor of time on a ventilator was inconsistent between the pre- and post-implementation group, which could have led to the discrepancy between the expected and observed outcomes of the scholarly project. If this project were repeated again, it would be beneficial to add inclusion or exclusion criteria that would focus on the amount of time the patient spent on a ventilator in the hopes of standardizing the amount of time between the pre- and post-implementation group. This could possibly help to create a standardized length of time of ventilator use for the participants and get rid of any outliers. Implications. The implication to quality is the improvement made to the compliance of evidence-based practice and protocols made by the nursing staff of the oncology ICU due to the implementation of the VAP prevention checklist. With a higher compliancy rate, it means that the patients of the oncology ICU received a higher level of care because of the implementation of the VAP prevention checklist. The implications for further research are that this project can be recreated in other areas where there is an issue with compliance with VAP prevention practices. This project could also be tailored to fit a different area of need where compliance is an issue. Additionally, the oncology ICU can use this checklist again to reinforce compliance with VAP prevention practice if they find that the compliance has waned without the checklist being used. Conclusion. Overall, through this scholarly project, a VAP prevention checklist was implemented in the oncology ICU, with the result being an increase in the nurses' compliance with the VAP prevention practices. However, it did not decrease the overall VAP rate of the ICU. The impact of this study was an improvement to quality and compliance with evidence-based practice and the protocols of the oncology ICU. Additionally, a higher level of care was created by the implementation of the VAP prevention checklist for the patients of the oncology ICU, and a more educated nursing staff was created. The main change that would be made if this scholarly project was recreated would be the use of inclusion or exclusion criteria to standardize the amount of time that the patient population spent on a ventilator. With this project being the first large research project for the researcher, the impact of this project was great. Overall, I learned the process of enacting a research project, how to adapt during the process, and the feeling of making a true impact with a research project. At this time, I would like to open up a discussion with the audience for them to be able to ask any questions they might have about my scholarly project. On this slide, you will find my references for this scholarly project. Thank you everyone for listening to my presentation, Ventilator-Associated Pneumonia Prevention Checklist, a Qualitative Improvement Retrospective Chart Review.